Welcome to our first educational OCT video. Here we will look briefly at some of the simple terminology found in ophthalmic OCT. OCT, or optical coherence tomography, uses a combination of optical techniques including low coherence interferometry and reflectometry to build up a cross-sectional image of semi-transparent tissue in order to provide diagnostic imaging and direct tissue measurements. It is used in multiple areas of medicine and in other sectors of industry and science. The technique was first used in the eye in the early 1990s, and the first commercial device available was released by Zeiss in 1997. The device sends out an infrared laser through a beam splitter. One beam goes to a reference arm and the other goes to the patient's eye. The reflected beam has undergone interference at each interface or surface, such as the retinal layers. This changes the appearance and time signature of the wavefront returning to the device. This is then compared to the reference arm wavefront. The computer then produces a picture from the difference in the interference patterns between the two signals. And the first devices that used this difference in time signatures of the wavefronts were known as time domain OCT devices. Things have obviously moved on since then. Modern devices use a slightly different technique. The computer compares the interference pattern in relation to the frequency variation between the reflected beam and the reference beam. This is known as frequency or spectral domain OCT, and most devices on the market still use this method. There are more modern devices known as swept source OCT, and this uses a faster scanning system with a longer wavelength, which allows for scans deeper into the choroid and faster scan acquisition with higher resolution images. There are newer methods of scanning in OCT, such as hyperparallel OCT, which we'll look at in a later video. The term A-scan comes from ophthalmic ultrasound. This is used to measure the axial length of the eye, especially in cataract clinics. However, in an OCT, it is simply the path of the infrared laser signal entering the eye and reflecting back from the multiple layers within the eye. Most modern OCTs can perform between 26,000 and 100,000 A-scans per second, but newer devices are reaching up to 400,000 A-scans per second equivalents. B-scan is a term which also comes from ultrasound. B-scans on ultrasound devices are used as cross-sectional imaging of the posterior eye when direct observation is difficult or not possible. The cross-sectional image we see of the retina is known as a B-scan. It is built up by numerous A-scans, allowing the OCT to paint a picture of the layers and structures. If you capture multiple B-scans across the posterior pole, for example, you can build up a volumetric or 3D scan. Also known as cube, map or mesh scans, these multiple B-scan outputs can help create stunning 3D images, normative data reports and thickness maps. In this example shown, we have a case of CSR, central serous retinopathy. This is also known as CSCR, central serous chorioretinopathy. On many devices, it is possible to overlay other images, such as colour fundus or CSLO scans, onto the anterior retinal surface, as in this example. We can see that the multiple B-scans have been taken across a 9mm vertical and a 12mm horizontal area over the posterior pole in this example. In total, 128 horizontal B-scans have been captured and placed together to build up a wider understanding of the layer thicknesses and total retinal thickness across this area. It is then possible to also compare these measurements to normative data. In a later video, we'll look at these in more detail and explore some of the issues with normative data. C-scans tend to be a top-down or bird's eye view of the structure we're viewing. In the image here, we have a C-scan of an optic nerve head. On some devices, the C-scan is a flat cross-section through what is normally a curved surface. With an on-fast scan, usually the curved nature of the surfaces is taken into account. The advantage of on-fast is that we can look at different layers through a structure. In this example, we have a left eye volumetric scan. We can see from the lower images that we can view different layers from above. The red box shows us the inner limiting membrane, the innermost or top part of the retina. The green box highlights the inner plexiform and inner nuclear layers. These are usually where the smallest capillaries lie in the vascular retina. The blue box is at the level of RPE-Bruch's complex. And the yellow box shows us the choriocapillaris and into the choroid's larger vascular layers. So in these examples, we can see how ENFAS helps us locate many lesions rapidly across the posterior pole. So at the layer of the inner limiting membrane, on this example, we have what we call macular pucker. We can see traction lines from an epiretinal membrane and also a pseudomacular hole. At the level of the inner plexiform inner nuclear layers, we have early leakage from capillaries in diabetic eye disease, and we've got fluid there building up. On the RPE-Bruch's image, we have a dome-shaped central lesion filled with fluid, which is CSR. And into the choroid, this is a normal view. But looking at the choroid on ENFAS is very, very helpful to spot nevi, for example, which will appear white or in negative, or things like choroidal neovascular membranes, for example. It's also important to remember that OCT is not purely an ophthalmic product. It is widely used in many more medical and non-medical arenas. The example shown here is a scan of a blood vessel allowing better understanding of conditions like aneurysms and clots, for example. And this is not OCTA, this is actually inside a blood vessel. Thank you very much indeed for listening.